Welcome everybody. Glad you could all make it tonight. You all know I'm Sarah Goldsmid. I don't have to introduce me, that's good. You're all sick of me already. You know who I am. I'm talking first of all about surgical oncology. The first cut is the deepest. I'm not going to sing it, sorry. No, actually, I'm not sorry. You're probably very happy that I'm not going to sing it. But it is one of my theme songs, I think. But yeah, I think before we get on to have David Lurie speak to us, who's our new radiation and medical oncologist, I was kind of going to do a little bit of a talk about surgical oncology. And this is kind of aimed for, I'm not going to spend a lot of time on fancy stuff. I just want to talk about general principles that are really important for everybody, because you're all doing oncologic surgery, I imagine, in practice. So hopefully some useful things. Feel free to interject, ask a question, make a comment. That would be great. Okay, so many of you remember Tony Moore, who worked with us, and Ogilvy wrote a textbook and did make the very good point that surgery is the oldest form of cancer therapy. You know, people can't live without the surgeon. I think that's really important to remember that. And that we've cured probably majority of patients in the past were cured by surgery, often alone. And despite a lot of other advances, we still play a pretty significant role in management of cancers. And David Lurie would admit that, I think, as well. Where is David? I'm going to ask him questions. Oh, okay, so I can pick on you. All right, good. Okay, and they also said in their textbook that you've got to understand the principles of surgical oncology to be successful, and you've got to, I guess, not just meet the needs of the patient surgically, but you've also got to support the whole family, the owners of the pet, through this process, because it's kind of scary when you get a dog come in and you say, oh, we're going to cut half its jaw off, it'll be fine, don't worry about that. It's really important. You won't get the person across the line to do the major surgery if they don't understand the process, and they don't understand the expectations, and they're also you know, worried about what the dog's going to look like or that sort of thing. So understanding and explaining to the owner is a really important part of doing oncologic surgery. Okay, so there's different things that we can achieve with the surgery. It might be that we're just aiming to prevent the cancer, so obviously over a hysterectomy is the most common procedure that we do in that regard, or castration to prevent mammary tumours or testicular tumours, particularly in, not necessarily in the scrotum, but also the cryptorchid testicles. So prevention of cancer is a big role in surgical management, I think. But also it can be used for making the diagnosis or staging the cancer, finding out what the type is, what the grade is, whether it's metastatic to the lymph nodes. So that's another role. And then finally, obviously, treatment. Okay, before we talk about anything else, I think the most important thing to remember when you're doing surgery, any sort of surgery, is Halsted's surgical principles. Where's Kyle? You hopefully know these. Where are you? Oh, right down the front. Okay, I hope you can remember these because you need them for memberships next week. So this really is the key to being a good surgeon, and it applies whether it's oncologic surgery or not. First thing, gentle tissue handling. Really, really important. The way you hold your forceps, the way you grab the tissue. You know, don't use Alice tissue forceps on something that's going to leave in. That's my opinion. You know, use tissue forceps, not your fingers, to retract. Or, you know, proper retractors to retract, that sort of thing. Really, really important. I say meticulous hemostasis, and that's true, particularly when you finish a surgery. You don't want it oozing blood at the end. But there are moments where you kind of ignore that. So, like the jaw example, you're halfway through doing that mandibulectomy. Don't stop and try and do hemostasis in the middle. Otherwise, you'll never get there. You just have to keep moving sometimes when you're doing some of these things. But once you've got whatever it is out, it's important that you have good hemostasis. So it's no point leaving that liver tumour oozing, or remaining liver oozing when you've taken out the mass. You do have to have meticulous hemostasis. Okay, preservation of blood supply. Naturally, if you don't have good blood supply to the remaining tissue, it's not going to heal very well. It's not going to have good immune response to potential infection. It's going to have delayed wound healing at best. So really important to think about the blood supply to certain areas. Don't want to damage them. Strict aseptic technique, really important to maintain that wherever possible. Obviously, some wounds or some procedures are less clean than others, but that's a really important rule. And that's just not relating to how you handle your instruments. It's all to do with how the theatre was set up, how clean it was, how your nurses prep the patient. All that sort of stuff comes into that. Minimum tension. I think this is a really big reason for failure. A lot of wounds that I see closed and break open. A lot of that's to do with too much tension left on the skin. So if you can reduce the tension by doing walking sutures or flaps or whatever, really good way of dealing with it. So I can remember several leg wounds, for instance, where somebody's gone to remove even a relatively small tumour. When you cut out kind of a, I don't know, soft tissue sarcoma or something on the leg, you make a wound that looks like 2 centimetre diameter and you think, oh yeah, it'll be fine. And then it kind of looks 4 centimetre diameter when you're finished. You go, oh, no worries, I look like I could pull it together. I'll just pull it together and suture it. I saw one dog with a leg come in that wasn't using its leg post that sort of surgery. And the foot was almost ready to fall off. Wasn't quite there. We still had, once we quickly undid all the sutures in the skin, it's like 2 days after surgery, something like that, and you could see the tissue suddenly kind of reinfuse. But it's very easy to lose a limb or at least cause bad damage to blood supply and venous return and so on, just by trying to put too much tension. It's better to leave it open than do that. So just keep that in mind. That's a big failure potential. Trying to get it accurately opposed is really quite useful for particular types of tissue. So say you're doing gut resection for a tumour or whatever, you really want to have good apposition. You don't want it everted, you don't want it inverted, you want to have good alignment of those tissues so it heals quickly, right layer to right layer, and doesn't have so much risk of dehiscence. So accurate tissue apposition is really good. You want to take the dead space out. So another good reason for failure. So you remove a big tumour, there's a big hole, you put some tension sutures in, or you just try and put skin together, but there's a gap underneath. And that's a good reason for failure, either because there's fluid accumulates and so it affects the drainage, or affects the kind of blood flow, or it causes wound dehiscence, whatever. Don't, in my personal opinion, try not to use drains to deal with that dead space. Anybody who's gone through an internship residency knows that I hate drains. There are places, and obviously I don't deal with abscesses every day, so I'm not talking about that, but I think drains, particularly non-closed, particularly open, like Penrose drains and so on, are inappropriately used a lot of the time for dealing with dead space. And I think they just add to the problem. They're slow wound healing, it's a foreign body, you're going to get ascending infection even if you cover it, and it probably isn't going to assist in the closure. You're better to use sub-Q sutures, like closing it with sutures, pressure bandage, anything like that would be better than putting a drain in, unless you use a closed suction drain. And that's okay because it's less likely to do all of those things. But you don't want to leave it in too long. Okay, there are some other, so they're Halster's principles, which Kyle knows back to front, but there are some additional surgical principles that I like to add in there, which I think are also important. And the first one that I remember being taught when I was a resident is that wet fat is happy fat, and that particularly when you're operating in the abdomen and the thorax, but also sub-Q or whatever muscle, you want to keep everything moist. Don't let it dry out. And if that means wetting a swab and placing it over the tissue, or having your assistant kind of drip some saline on it, or whatever it is, you want to keep stuff moist. Make a skin incision large enough for the job. So an example of this that I think led to led to the vet not ever being a vet again. So it's not really oncologic, but anyway, it's a good story. So cryptorchid testicle, not in the inguinal area or in the kind of area between the inguinal area and scrotum. It was in the abdomen. Small incision, because that's what you do to make the owners happy. You do a small incision. Found the vas deferens, follows the vas deferens down to the round structure, removes the round structure, closes it up. Has obviously an inkling that there's some issue, so puts said round structure in a formalin jar, and 1 day later, when the dog wasn't peeing, brought the dog and the bottle of formalin into me when I went, oh, that looks like a prostate to me. And it was a prostate. So they'd followed the vas deferens down one way and found in a very dark hole with no suction and poor lighting what they thought was the appropriate structure, but as it turned out it was the prostate. And so that dog had basically had a tied off urethra and was leaking into its abdomen urine, which is probably why it was still alive one day later. So I had to do a urethral anastomosis. Dog developed a stricture, long story basically, but the dog didn't survive because the owner opted for euthanasia because it had incontinence as well. And yeah, the poor vet decided that this was too stressful to be a vet. Not that it's a well-recorded actual complication in the literature, but it was basically because you couldn't see properly. They just didn't make a big enough incision. So if you're doing a laparotomy, say it's an exploratory, you don't know if there's cancer there or whatever, don't make a keyhole and kind of just look. You've got to actually make a big incision. It's going to heal just as quickly if it's this big or this big because it's healing side to side. So don't, the owner's going to cope with that if you just explain why you did it. But don't try to do everything through a keyhole. It's not worth it. And if you went into that abdomen and you didn't know what was going on, don't just come out. Take biopsies, because at least then the owner goes, oh, that's great, you did something. Don't just kind of go, well, I didn't find anything. If you've got a dog with GI signs and you think there's something going on, take stomach, jejunum, duodenum, ileum biopsies, maybe the liver, maybe a bit of lymph node, something. Even if it looks grossly normal, it often isn't. So don't go in there without doing something. And adequate pain relief, really important. As surgeons, we're not always the best at recognising this or dealing with it, but really important part of our surgical principles. Housestead probably not so much back then, but now I think it's really important. Not just that, I'm about to talk next week on behavioural issues around surgery, pre and post, and I'm learning a lot from Kirsty. So it's really important to think about anxiety in these pets, not just pain, but anxiety, stress, fear, and dealing with that as well. I should add that to my slide, I think. And it's really important to do pretty skin sutures because no matter how good a surgeon you are, if you can't do nice skin sutures, the owner's going to go, oh, they can't be a very good surgeon. That doesn't look pretty at all. And unfortunately, that's what you're judged on. So, important. Okay, so biopsy, if at all possible, is really good idea before any surgery. So if you have, and it doesn't have to be a biopsy, you might be able to do just a cytology and have an answer, but knowing what you're dealing with rather than just going, oh, it's a lump, I can just take it out. It would be really helpful to do that first if you possibly can, and it's not always possible, I realise that, but it might change how you plan things. So if you know you've got a mast cell tumour, you might take a bigger margin than if it's a benign adenoma, for instance. So knowing that will change what you do or what you recommend or whether you refer it even. So that's a really big thing. It's really important to know what it is because then you can talk to the owner about the prognosis. So if they don't know that this mast cell tumour could be aggressive and could cause all sorts of problems down the track, and that happens and you haven't given them a notice about that, you might end up with an owner that's unhappy with you even though you did a good surgery because they weren't expecting that. And so kind of giving all of the explanation to the owner in writing as well, because they probably forgot everything you said, I think is really helpful. Aim for a cure, obviously, if you can, is a good aim, but it isn't everything, and sometimes we're not aiming for cure, and probably David knows that better than me, because you're not a surgeon. But it is hard to sometimes cure these patients, but we're going for quality of life, and for a lot of owners, they are so thankful for that extra year or whatever you gave them. Even knowing that you're not curing it, it can make a huge difference to their life with the pet. So I think that's a really important thing to think about. We don't always cure, but that's okay. Planning is really helpful. So it's always good to have a plan B. You make a big opening, remove a skin tumour or something, and you go, oh yeah, I should be able to just kind of pull it together. But you can't. You need to have a plan B, because once you've got the big opening there and you go, oh shit, I shouldn't have started this, it's really helpful to think, oh yeah, but it's okay, I've got this inguinal flap, I can rotate it, or I could use the caudal circumflex iliac, or I have another plan. And I usually like to have a couple of plans when I get into surgery, because sometimes you just don't know. You might cut a bit more tissue out, or you might might look different once you've got it all out and everything gets bigger, or the wound looks bigger. It's really helpful to have a couple of different plans, and I do, in my mind, have quite a good three-dimensional way of looking at it. So I can kind of think, oh yeah, if I move the skin here, it's going to reach here. But if you can't do that, it's worth doing some drawing on the dog before you start and kind of rotating things around and going, oh yeah, that should meet here, and do a rough guide of where you want to cut something out. You say you've got a mass and you want to take, I don't know, 2 centimetre margin or something, draw it on with a pen, with a marker pen. Try not to scrub too hard when you're prepping it. But have a plan beforehand and then look at how you can close things over it. We often use 3D reconstruction because we're lucky and we have a CT scanner and we can do 3D reconstruction. But say we're doing a bony tumour in the jaw or something like that, I can plan from my 3D reconstruction what level I'm taking it off and how much tissue I'll have left, and whether I'm getting a margin on it. All that sort of stuff really makes a big difference to how successful the surgery might be. And don't cut it if you don't think you're going to make a difference. So I think, do no harm first. And if it's necessary, don't be afraid to refer something. The owners will value that if you think that that's appropriate for them. And I'm not trying to say this, obviously you can do a lot of things in practice, but there are some things, particularly if you biopsied first and know what it is, that you might want to refer. Okay, principles of biopsying. Think about how you're going to biopsy. So, worst thing I find is, say you've got an oral tumour, okay? Maybe not this one, but an oral tumour. Don't go biopsying through the lip, for instance. So you might have the temptation to kind of go through the lip because it's just there. It would be way better for us. This is an extreme, so just happen to have a picture. But if you biopsy through the mouth where you're going to remove it if it had surgery, way better. Same with tumour anywhere really. You just want to make sure your tract is going to be able to be resected if it's the area that, if you're going to resect it or do surgery on it later. So obviously this looks like a primary bone tumour, distal radius. So if you're going to biopsy that, what would you use to biopsy that usually? Jam sheeting? I think you can do it other ways. Sometimes you can even get an aspirate out of that because the bone's so soft. But a jam sheeting is the standard way to biopsy bones. So if you have never seen a jam sheeting bone biopsy forceps, punch, whatever you want to call it, that's what they look like. So they have like an outer sheath. It's a bit like a big catheter. Has an outer sheath. It has a kind of stellate down the middle of it. This pokey thing is actually to poke the bit of bone out once you've got it in there. Once you've taken your sample, you use that to push it out. And you should end up with like a core sample. And you want to take multiple sites of this. Sometimes I'll actually x-ray it after I've taken the biopsies so I can make sure that the biopsies are representative of all of it, and just don't take the middle. You want to try and get a bit of normal tissue on the edge if you can, not right out too far, because I just said don't do that if we're going to cut it out. But you want to get kind of somewhere towards the rim of it so you know you've got representation. Okay, so here's a typical lesion that you might see. Little raised skin lesion, could be nothing, could just ignore it, could easily do an aspirate. And if you got that, what would you be worried about? Cell tumour, yeah. So they're usually fairly obvious on cytology, but that makes a big difference. You're not going to treat this as a benign lesion. If it looks like that on cytology, you'd be worried. I mean, of course, you need pathology to be sure. So the last one I had come in had an aspirate. It was actually a bigger mass than this. It was on the ventral neck. Cytology looked like this and came back from the lab as a high-grade mast cell tumour. I'm taking that seriously, so I CT the dog's neck, chest, abdomen, because that's how we usually we like to CT them if we can stage them like that, because then we look at all the organs. And so for a chest CT, you can see less than 1 millimetre diameter lesions, which is great compared to a chest radiograph, which you'll see down to about 3 millimetres. So good chance of picking up if there's something there. I CT'd this whole dog, no metastatic disease, but it did have an extra mass, besides the one I could feel. It had kind of an extra, almost fluid-looking mass deep to the mast cell tumour, wrapped around the jugular and the carotid. So, okay, I'm not going to be able to resect this, but I need to get it out for pathology because I don't have a grade and I don't have full pathology. So, and at least if I do that, then I can pass it on to David and he can do the management afterwards. So I cut out the mass and I go into this kind of second lesion and out pops the grass seed. I went, oh, it's a grass seed, a very expensive grass seed because I've just CT'd the whole dog. But you actually could see the CT on the grass seed and, see the grass seed on the CT. And Karen Hoffman actually diagnosed the grass seed before I got in there. But I sent off obviously the mass that we thought was a mast cell tumour and it wasn't. So you can make a mistake on cytology, even if it's done well and a pathologist looks at it. Sometimes you do get a different finding when you actually send it off for pathology. Likewise, another unusual kind of looking mass could be benign, could be cystic, could be hemangioma, hemangiosarcoma. Same with these, you just can't tell without taking a biopsy. Now some of those you might do an excisional biopsy for. That's okay if you think you're going to just have one chance at doing this and it's one anaesthetic, whatever their reasons to do an excisional biopsy if you think that's better, but go for a margin on it. Okay, here's a lymph node. We probably want to aspirate that first to have some idea what we're dealing with. Maybe it's lymphoma, maybe it's something else. How would you go about biopsying that? What sort of options do you have? I can hear mutterings. Yep, so you could just do a cytology, you could just do an aspirate. You could do an excisional biopsy if you wanted to just remove it. I don't remember if we actually knew the primary, but anyway, there was a large lymph node. The other alternative is to use a true cut biopsy needle for sort of a solid sub-Q mass like that. Has anybody not used a true cut biopsy needle? Yeah, I think there's a few people who probably haven't seen one or used one or don't have them in their practice, but they're quite useful to take a sample of, like a little core sample of soft tissue. It doesn't work in bone, but in softer tissue, quite a useful way to get a sample. If you've never used one before, I actually have some here. And if you promise not to biopsy your hand, I've got some apples. And if you want to just have a feel, because it's a little bit of a technique to know how to kind of insert it and then fire it, then pull it out, then get the little sample of tissue out with a little needle. So yeah, you put it enclosed to the edge of the tumour, you push this in, and that's where it's going to take the biopsy from. So you need soft tissue because it has to kind of roll into that little space. Then you fire it, and this kind of knife sheath fires down, and you collect that sample and then pull the whole thing out, and then you open it up and use a little needle to push it off. And I usually put it onto a little piece of paper, maybe a bit of the suture packet or something, a little bit of cardboard, or you can use a little cassette that you can specially get to put little samples in. I usually use like a 25 gauge needle to roll it off so I don't damage. So that's another thing when you take the biopsy, don't crush it with a forceps. Be really gentle with it to not change the architecture. So just use a needle, push it off, put it onto the bit of paper, whatever. That's what I do with gut biopsies, put them on a bit of paper and then drop them in the formalin. But yeah, so if you want to kind of see one, use one, handle one, don't do what my nurse at the uni did once, and she was cleaning it and got it caught in her hand. And she came out to me with the true cut in her hand and went, "Sarah, it's stuck." Because she'd got it, she was at this stage here. The only way I could think about getting that out was to fire it. I fired it and then I pulled it out. Anyway, she had a normal biopsy of her hand. Yeah, so be careful with them. They are pretty sharp and you don't want to poke it through your hand. Okay, don't spread the cancer if you can help it, and potentially you could spread cancer by doing the surgery, and so the way you handle that tissue, so you don't want to, if you've got a dog with multiple lesions and some are lipomas, don't do the lipomas secondary to the mast cell tumour, for instance, because it is possible to seed the clean site with the dirty cancer. So yeah, you want to be really careful what order you do things in, whether you change instruments, whatever it is, don't spread the tumour. And certain things are more of a concern, so if you try to do a biopsy of a liver mass or something like that, you can do it, particularly with ultrasound guidance and care and warning the owner and maybe doing coags beforehand, but there is a risk of seeding tumour if you're not careful. Same with splenic mass. Okay, change instruments, I mentioned that. So, you know, you might have a lesion on the foot that you're biopsying, but the lesion up, or you're removing whatever, don't do it with the same kit, just in case. Correct biopsy techniques. In a way you take the biopsy, you don't want to damage the tissue. So don't burn it, don't laser it, don't kind of crush it with forceps, because it's never going to look the same architecturally for the pathologist. And if you're only taking little samples of it, don't just take one. I think medicine's rule is at least 4 of the gut biopsy, and then you'll definitely get a diagnosis, apparently. Yes, I don't use cautery. Okay. Mention that, don't crush it. Keep the orientation. So when I'm taking out, I don't know, any tumour, and I want to orientate it, so I want to know what's dorsal, what's ventral, whatever, you may want to put some sutures in. That's quite useful. So I might put 2 sutures on one end and say that's dorsal, and 1 suture ventral, or technically you only need the dorsal. So yeah, identifying it for orientating, because you know the pathologist gets this lump and it doesn't look the same as when it came off the dog. So you need to kind of give them some orientation would be helpful. 10:1 formalin, that was drummed into me when I went through, but you know, it's very hard when you have a big spleen and then you take a little sample and they say insufficient sample. So, you know, there's a limit to how much you can send in, I guess. Inking it, I don't know if anybody inks their margins. I do sometimes do that, or I'll use the sutures. Here's a biopsy of the gut. I think I mentioned to you. So here I've made an incision in the gut, and I'm just using a little medicine balm to take my full thickness gut biopsy. It rolls up like a little worm, like a little coil. Don't use forceps on it. Put it onto a piece of paper. That's my gut. I'm just about to do some single interrupters to close up, but put this on paper and pop it in formalin. And then you have lots of samples. Poor Orana. She's about to sit at fellowships. She's very worried. Okay, inking margins, if you want to do that, that can be quite useful. Sometimes the pathologists say it does just hard to read the right at the edge, but it does give you better orientation, so you can be really fancy and have lots of coloured ink, like that. It looks like that. So you can kind of say, where did you actually cut the edge on? That could be very useful. Okay, having some idea of the behaviour and where it might go is really useful. So we don't know what that is. What could it be? Perineal adenocarcinoma? Anal sac adenocarcinoma? Could be benign, could be an abscess. Kind of doesn't look right for a perineal hernia, but I guess it could be. Okay, whatever that is, if it was neoplastic, where would that go? Where could it go? Sublumbar lymph nodes, medial lately, whatever you want to call them. Further forward in the abdomen, into a lymph node. Could go even further, could go to liver. Not so likely to go to the chest, but stranger things have happened. So you need to know that, because say it's an adenocarcinoma, whether it's anal sac or whatever, firstly we'd probably want to check its calcium level, just to be thorough, and we'd do bloods anyway, but we'd want to look at its abdomen at least, if not its chest. And so I'd probably do a CT scan, chest and abdomen, or at least an ultrasound of the abdomen. And there's quite a few of those adenocarcinomas that go to those lymph nodes, but all is not necessarily lost, as we can remove those lymph nodes. And these are actually, you know, we can surgically remove them, but if there's not a good margin, which there usually isn't in that area, because you've got to cut things with names that probably should stay, like the rectum. So then I probably would give them to you now, because I didn't realise that we can now, till now, that we could do radiation therapy on some of these. So, you know, understanding the behaviour of the tumour and then all your options can make a big difference to what we can do with these. Okay, mammary tumour. That's going to go into the abdomen potentially, or inguinal lymph nodes, for instance. We need to know that, because that makes a difference to the prognosis and so on. Should look in the chest. Okay. All right, so moving on from biopsy, I guess, to treatment. Definitive primary cancer treatment. Obviously, we can cure quite a few things, but sometimes all we can do is just remove, or we might remove residual disease, but sometimes we can only debulk. We can go for palliative. We can't necessarily always remove the whole thing, and I don't think that's wrong. So if I got a dog with a huge soft tissue sarcoma on its leg, but it has bad arthritis and they don't want the leg amputated, even though that might cure the dog, it might not be good quality of life. We've got to maybe do something for that ulcerated mass that's not likely to spread, but is likely to cause quality of life issues and infection and so on. I think that's okay to do palliation in those cases, as long as the owner understands what you're going to achieve. You might resect metastatic cases. We'll look at some of these in a minute. Oncologic emergencies, palliation, and then you've got to reconstruct them all and rehab them. So best surgeons, according to Ogilvy and Moore, know what the cancer is before they start and what it's likely to do and how likely we are to cure it. And they kind of work out the dose of surgery required. So are you going to be really aggressive or is that not worth it? Is there anything else we can do with it? Like could we add radiation therapy or chemotherapy or some other adjunctive treatment? And is that worth it for the dog's quality of life? And you've got to make that decision with the owner. So you need to know all of that to kind of give them the right answers. It's important to kind of assess the patient. So there's no point going ahead and taking out a mammary tumour here till we address the other issues going on in this patient. Oh, I think I did something bad.
Just press the middle button.
Oh, middle button. I slipped. I missed the wrong button. Yeah, look, I'm a great surgeon. I just slipped on. I hit the. Oh, how did you do that? Oh, smarty pants. Okay, I'll just stick to surgery. Okay, you've got to think about patients sometimes, depending on where the cancer is and how cachectic they might be, or don't want to eat because it's a head tumour or something. You want to think about nutrition. Never forget that, and think about pain relief afterwards and anti-anxiolytic if needed. Yeah, you want to, if you're taking it out in completely, you want to think about the drainage, the venous and lymphatic drainage, so that doesn't spread it. And you want to remove lymph nodes for staging, or at least aspirate if you think that's indicated. So this tumour needs to be removed. That's what I said about drawing on it first. It's going to leave a big hole, but at least you know what you're going to deal with. How would you remove that? Say that's a soft tissue sarcoma, for instance. I don't actually know what it was. What options do we have to remove that? Take the toe. Can you take, how many toes can you take if you had to?
2, 3.
Can you take all 4 main toes with that? Well, not for this one. I'm just saying in general, could you do that? Yeah, you could. Dogs are amazing. They can cope with, all they need is a pad underneath. I wouldn't recommend it if you can avoid it, but I'm just saying the other thing you might be able to do, and it depends on where the tumour is or why you're removing tissue, but don't forget that a toe's great for filleting out and you've got skin and you can close things with it. So it's actually quite a nifty kind of way of closing a wound, as long as, say, the skin wasn't being affected by the tumour or whatever, you know, so you've got a margin. You could fill it out the bone on the next toe and wrap it around and give yourself a closure. It's actually really useful for those sort of areas. Okay. All right, this is one I did the other day. So order of the surgery, I mentioned this already. This dog has a soft tissue sarcoma on its leg. I actually saw David. They talked about options of amputation. Would have cured the dog, but as I said, some dogs aren't a good candidate for that. So this owner didn't want to go for that because the dog has arthritis. It's had a knee surgery for cruciate rupture. It's got other arthritic problems. Dog's not going to do well with 3 legs. Walking on this leg fine. Mass is growing. It turned out to be a grade 2 soft tissue sarcoma. No metastatic disease. But she wants to do something about this. We can't guarantee a cure. She couldn't go for the radiation for various reasons. So we went for as good a surgical excision as I can do, which is limited in that area. If you're going to do a limited excision, take a fascial plane at least. So a full thickness fascial plane underneath is about the best you can do in this area if you have to do a local excision. And the pathology actually came back that I didn't have a margin deep, but what they don't appreciate, I guess, when you take a fascial plane underneath, just it tends to contract as you pull it out. So sometimes you don't even necessarily get a representative pathology on that because it shrinks, but you have no choice. And we didn't get an adequate margin on this, but I might still have held off a problem for a while at least. But my point was order of the surgery. So you're cutting a big hole here. We can't close that. Like the description I gave before, that foot's going to fall off if I try and pull that together. We're going to end up with a reasonable hole because I am taking wide margins on it. But we're we wrote a paper here on free grafts straight after surgical removal of a tumour, put straight onto tendons and muscle and everything. You can do that and have 85% take easy. The 2 I did this week, similar like that, we had, I think, 90% take. I didn't see the last bandage change, but they both looked really good when I last saw them. But order, we would take the skin graft first. That's clean tissue. We're going to take that, we're going to do our mesh graft, then we're going to do the surgery here, so we don't contaminate one to the other. That's what it looked like after the graft. Okay. First chance is your best chance to cure. And if you don't think you can do it the first time, that might be a good case to refer, because it makes it so much easier to cure it if you get the first chance at it. What really makes my life difficult is if somebody's gone for a resection, not been able to get a margin, and then put, heaven forbid, a Penrose drain coming out like 10 yards away. No, I can't use that, 10 centimetres away. And then I have to take everything, including that tract out, if we're going for cure. So, yeah, try not to do that. But if you're not sure you can get a margin, say you're worried it's on the body wall and you're not sure if you have to take body wall, A CT would probably tell you that, and that would be really useful. And if you don't have one, it's a good imaging technique for those. B, if you're worried about taking chest wall, probably good to send that one on, because if you don't get a margin, it's much harder the second time to go back in. So think about that. Yeah. Okay, squamous cell carcinoma on the nose. We have options now of radiation. If they're really superficial, we've still got strontium here, so we can do, is it 4 to 6 millimetres depth for a strontium? Yeah, so if it's really superficial, we do have that in-house, but we then can also send them out for radiation, but we can also chop them off because, you know, I'm a surgeon and that's still not a bad idea. And I'm sorry, this is obviously not the same cat unless it also changed pigmentation. But anyway, you get the idea. Okay, and we can do all sorts of fancy otomies and ectomies, which I'll show you a few slides, but that's, my point is really the principles here. But you can take pretty much most things. You do need a heart, although you could take the pericardium. You can take some of the brain, but most things are kind of parts of them at least redundant, so that's kind of good for us. But lots of fun things that we can do and take bits out. Okay, here's an example. This poor puppy had chondrosarcoma attached to its trachea. Couldn't breathe very well. That was it. Pretty nasty. Okay, resected a tracheectomy. Dog did well till it came back, but at least we kind of gave it some more time, good quality of life. The owner was happy with that outcome, even though we couldn't give them a long-term prognosis. Here's another one. This is a dog with an intranasal squamous cell carcinoma. The owner just happened to see this little bit of pink tissue in the nose. Had a CT scan. There's the tumour inside, so on the medium septum. So I use this technique that I think we've got 3 cases now. We should write it up, but anyway, I use this, that's just another cross-sectional view of the CT. So I use this technique, which isn't described, and I don't know what we should call it, nasal flappy technique, I don't know, where you just kind of continue up here and basically open the flap so you can see inside. It only works for very specific types of tumours, but it was really good for this one. So here's the tumour, here's the flap so I can see it, and then we go for resecting that, okay? And so I've marked it with sutures, so this is caudal, I think, and this is cranial, but I've got a margin of normal tissue around that, and then we closed it. Kind of looks a little snotty at the beginning, but I don't think it looks too bad at suture removal and recheck, and that dog went on and has not had recurrence that I know about, unless somebody else knows about that case. Okay, liver tumour, again, CT scan, big liver mass, staple gun, remove it, change gloves if you're going somewhere else. Okay, residual disease, so we commonly get cases come in with a previous surgery site that says inadequate margin, and that's all right, they gives us a challenge to do, but often it's hard to get a margin in this sort of area, whatever you do, and that's when you might well need some adjunctive therapy. Could be radiation therapy or something else. So yeah, not always possible to cure that. Okay, metastatic disease. You can take metastases out. The most common one that I would do is for perianal tumours going to the sublumbar lymph nodes or medial iliac lymph nodes. They can still do quite well after doing that. There's reports of MET plucking, I think Rod Stewart calls it, MET plucking osteosarcomas out of lungs. I'd never really done that, but it might be appropriate if the metastatic disease is likely to cause problems, like constipation or something. Oncologic emergencies we do get. Obviously, ruptured spleens are probably the most common thing that we might get through emergency, but it could be intestinal obstruction or perforation or something. Could be a thoracic wall lesion that's bleeding. Prostatic disease. We've had one relatively recently that had nasty prostatic carcinoma. It was non-resectable. We did urethral stent that for a while, so it could pee for a little bit longer. So there's some oncologic emergencies that we might have to deal with. And palliation, we might amputate that leg, but we know that there's at best a 10% without chemo, 10% chance of giving that long-term success. But it's still worth doing because the dog's much more comfortable. And all sorts of fancy recons. I've already shown you this is another mast cell tumour that had a resection, wide resection and a free skin graft. Okay, that's it. I can't even see the time, but I think it's about right. Any questions? There's going to be a break soon after. We're going to have Hills, who's sponsoring us tonight, and courtesy of them we have nice food, and you're all able to come. So thank you, Hills. Oh, so we're going to have a little chat to her in a minute. Were there any questions about? No, I bored you all. Okay, so we'll do that now, and then we're going to have a break, and there's going to be more delicious food very soon. You're going to sort that out.